So again, welcome, and we will go through the usual protocol here, but in a streamlined fashion though, in terms of opening notes, reminders. We are going to skip introductions today because our fantastic presenter, Dr. Hansen, is right on the cusp of clinic, and we want to make sure we have enough time for her to present and have a discussion before she has to take off and do the work. So a couple reminders, if you are in a setting with multiple individuals, if you would put all of your attendees' names into the chat so we can keep track of CME and attendance and all those things. If you could mute your microphones, I'm hearing a little bit of background noise, but if you could mute your microphones if you're not talking and then say your name when you unmute, that would be awesome. And of course, if you're able and have the capacity to do so, video on is always lovely to be able to see your lovely faces. Did want to also let you know about a couple of other Echo programs that may be of interest. So these are the contact links and information for some of our partner work, including a traumatic brain behavioral health echo that occurs on opposite Fridays, which competes with Echo Geriatrics a little bit, I think. Of course, there's also the Psychiatry and Addictions, Telebehavioral Health series. There is the telephone consultation for the UW pain and opioid provider consultation hotline that's available, and the case conference series, which I'm thinking, Barack, you were involved or are involved with this in some way, shape, or form. I also see your hand up. You have
Yeah, so
you have an early question.
yeah, a hand up, not because of telepain, but yeah, I support it. I was just asking a separate question, so didn't mean to interrupt you, about the December 23rd Echo, which somehow didn't get canceled off of my calendar, but I just heard this is the last of the year. So no Echo on December 23rd.
We are giving you the gift of time on December
Good.
23rd.
Okay.
There will be no second.
Okay.
Yep.
Good. Somehow that didn't cancel it off my calendar, but so thank you for confirming.
Got it. You may not be the only one for whom that is the case, so thank you for bringing it up. We do not have a case for today, but we hopefully will have a great discussion, and just reminding everyone to be sure not to disclose any PHI. You will get the 1-minute post-session survey, and we really have valued your feedback over the year, which has helped shape what our upcoming didactics are going to look like. And here is our list all the way through the end of May, and we have some other presenters and ideas about what the rest of the year will look like, and are working with some folks to figure that out. If you have additional suggestions, please let us know either in the chat or on the survey or an email in between sessions. Really do want to make this as beneficial as possible for our community. Oh, there you go. Again, the gift of time for you and yours in the holiday season, whatever that may look like. So no session on the 23rd. Oh, also wanted to alert you to a neurology update for primary care CME event, which will be occurring Friday, March 3rd at Swedish. So there's a link that will be in the chat, it looks like, if I'm reading that slide correctly. Great. So that, wanted to bring that to your attention. It looks like it is virtual. So if you can tolerate a long day of virtual learning. Cases, we want them. We know you have them. It'd be great to get more of them. That's all I'll say about that. The end of year survey. Oh yeah, so there's a larger survey, which we also will be relying on to help reiterate or iterate and revise our work here. So keep an eye out for that. And it is a huge component of our ability to continue to offer CMEs for free. So just a encouragement there. We are accredited through the University of Washington for CMEs. We have no disclosures, neither our presenter or any of the planners. Of course, there's a mitigation process. The hub team, we've been doing this for a couple of years now. Here are all of you, and this is updated to reflect all of our sites. We are almost up to 120 people who have participated in this, and just, again, lovely to see such a diversity of locations and expertise. And with that, Speaking of expertise, I am going to turn it over to our fantastic colleague, Dr. Angela Hansen, a geriatrician at the Memory and Brain Wellness Center. And that should not read acting instructor. That should be assistant professor of gerontology and geriatric medicine. So apologies for the old information there, Dr. Hansen. And I'll stop sharing. Turn it over to you. And you are mute. Oh,
great. Can everyone hear me now? So thanks everyone for inviting me to give this talk, and let me know if you can no longer hear me or anything you need. I do research in diet and dementia prevention. Specifically, I do research in is there a one size fits all, or actually is it different for different groups at risk? So I study specifically a group at risk for Alzheimer's that have the risk gene ApoE4. I didn't put any of those slides in here because it's very early data, but basically, we have some interesting data to suggest that higher fat diets might be better, or at least not worse, for people with that genotype. And so we're actively trying to study, are there different diets that are better for different people at risk for dementia? So it may not be that one diet fits all. But I'm going to just talk to you a little bit about the evidence for diet, and what do we know about diet, and what should we be telling our patients until we have that kind of personalized medicine, which we really don't have right now. We sort of have a hodgepodge of things. This is kind of what I'm going to be talking about, a brief overview, some of the evidence, various diets that have been studied, compared and contrasted. And then I talk a little bit, I think I have very brief slides on different stages of dementia. Are we talking about prevention? Are we talking about advanced stages? And then really what my goal is to open it up for questions and discussion. So I'm hoping, or maybe you have all seen this or not. I don't know if people want to raise their hand or how active you all are as an audience, but who has seen this weird snake figure before? Is this familiar to anyone? This came out in 2017 from the Lancet. And what it was is a guideline. It's basically a very fancy epidemiology study. They took a lot of cohort studies and calculated risks and said, aha, these are the 9 risk factors for dementia that are potentially modifiable. And then in 2020, they added 3 more. So, and then they'll probably keep adding, so watch that snake to grow and shift around in the sand there. But this is the risk. This is the most up to date that I could find. Maybe somebody else has updated this, but these are sort of 12 risk factors, potentially modifiable risk factors for dementia. And you notice that diet is not on here, or bad diet, I guess. But I'll just read through them a little bit. So low education. And what they mean by low education is not going to primary school. Okay, we're not talking about like you didn't go get an MD, but low education in terms of primary. Midlife risk factors, and they define midlife. So hooray, we don't have to argue about it. It's 45 to 65. You may hear other definitions, but they define midlife as 45 to 65. So midlife risk factors include hearing loss. That's a pretty big relative risk. In fact, I think it's the biggest one on here, with the smallest confidence interval, which I deleted for space. But hearing loss, traumatic brain injury, hypertension, alcohol, greater than 21 a week for all genders, obesity, and high BMI. So those are your midlife risk factors. Late life risk factor is smoking, depression, social isolation, physical inactivity, diabetes, and air pollution. You'll know, so like I said, diet's not on there, but I bolded the ones that diet might affect. So your diet certainly can affect hypertension if you're eating a high salt diet. Alcohol is a part of diet. Diet can certainly affect obesity and then diabetes. And then I put social isolation here just because, you know, when I think about diet and eating patterns, and, you know, if we're socially isolated, does that change how we eat? Or if we're not socially, if we're eating it communally, does that change how we eat? And if we're communally eating, do we need to change how we communally eat? What we're communally eating as a group? And let me know if you think I should have bolded more or less of these. I almost bolded depression because depression and, you know, food and eating probably are linked. But these were the ones that seemed to stand out for me about that. If you study diet, you can't help but study. You also study hypertension, diabetes, obesity. So this is a slide that I definitely wanted to put on here. And I guess I could have put it at the end, but these are references that I use heavily for this talk and just in general. So the first one is the Global Council on Brain Health. And if I was really quick at Zoom, I would stop screen sharing and just show you the PDF of this, which I have in my hand right now, which you can see. But I highly recommend, you know, finding this on the interweb and downloading it and just putting it into your repertoire of references. It's not that long of a PDF, and it's a really nice resource. And if you have fancy Adobe, you can cut it up into like the 5 pages that are really helpful and give it to your patients. I have that in my hand right here. We'll go through it later, but it's basically like nice. Here's what you can do as an individual, healthy foods and what you can do right now. So the Global Council on Brain Health. Diet for the Mind is a book by the late Martha Claire Morris from Rush University, who studies this. She kind of pioneered this work. And then this review article, which I'll go through. There's lots of more references and resources, but those are 3 big ones. All right, so what should we be eating? So these are kind of some takeaways that I'll go over, but I'm starting with a takeaway slide. There are likely several different types of diets that are healthy. And I think about this a lot because, you know, there's the best studied diet that we're going to go over is the MIND or Mediterranean diet. So the Mediterranean diet or the Mediterranean modified diet, which is called the MIND diet, is what I call the best studied diet. And my colleagues will have heard me say this, but it doesn't necessarily mean it's the best diet, because a lot of the studies, as you'll see, are Western centric, and they don't necessarily study all cultures' diets, and they don't necessarily study, oops, sorry about that. What just happened? Sorry, my mouse is really sensitive. They don't necessarily study all the diets at once or compare and contrast, but we can use it as a guide and make some common sense comparisons. You know, if an apple is healthy, a pear is probably also healthy because they're pretty similar. So there are likely several different types of diets that are healthy. No one food or supplement will cure or prevent a complicated disease. That's just a truism that we can just take to the bank. Pick a diet you can live with. You know, if you're trying to lose weight to fit into an outfit for a wedding, whether you're in that wedding as a bride or a groom or mother of the bride or something, sure, you go on some crazy fad diet, lose weight for a wedding. But if you're making changes, if you want to make changes for your life, like I want to eat healthier for my midlife, which we know is 45 to 65, or I want to eat healthy, I want to have my kids eat healthy, I want to teach my kids healthy eating habits. You know, a crazy fad diet's not going to be it. It's a diet you have to live with. It's changes that you have to sustain over years. And then you want to tailor your recommendations to your patients or to yourself or to your community to the goals of your patient or the stage of disease. So what I'm talking about here now, bringing this back to Alzheimer's, if we're talking about prevention of a healthy older adult, you know, that's I think a different conversation than if we're talking about maybe MCI. Someone has they have MCI, but maybe they're still working or they're very active, retired. You can maybe be pretty aggressive risk factor reduction. Sure, try that ketone diet. Try that, you know, try aggressive blood pressure control. Try all these different things. But if we're talking about someone with moderate to advanced Alzheimer's and they want to eat ice cream, here's my diet for them is let them eat the ice cream. That's my trademarked diet for someone with advanced Alzheimer's is let them eat the ice cream. Because at this point, you're not probably going to modify their disease by diet. Okay, so what are some of the what's some of the evidence of these diets? So the Mediterranean diet. So a lot of this evidence comes from really carefully designed cohort studies that include autopsy studies and MRI studies. So for example, this was a French and then another Australian study. They followed older adults. They had lots of data about what they're eating, very careful food frequency questionnaires, and then they had MRIs. So both in the French and the Australian studies, they followed their white matter, and then they followed their hippocampal volume. So I'm going to show you their scans on the next slide here. So this is some white matter disease. So this is just some example of low and high white matter. So white matter change is examples of, damage to the axons, and you want less of it. And it can also go along with hypertension, diabetes. And then hippocampal atrophy. Of course, hippocampus is a part of the temporal lobe of the brain that is important for turning short-term memories into long-term memories. It's named the hippocampus because it looks like a seahorse to somebody, to a pathologist many years ago, or somebody. Anyway, atrophy of the hippocampus is an early and sensitive sign of Alzheimer's, and it can be in other diseases as well. And on this slide, we can see on the left here, we see a healthy brain. These are some images that we get. We get images similar to this. These are all from studies, so they're not our own patients. But this is a healthy brain, the coronal section. You can see the ears here, the temporal lobes here. The hippocampus, you can kind of see a seahorse, I guess, if you use your imagination. Nice and plump. The inferior lateral ventricles are nice and small, whereas the brain on the right is just more atrophied overall, and the hippocampal volumes are much smaller, and the space around are much bigger. And so just to go back for a second, people who followed a Mediterranean diet tended to have larger hippocampal volumes. So there's just lots of this evidence that accumulated over the years. Some of this data came from Rush University, which is where Martha Claire Morris was from. And they designed the MIND diet. So what they did was they combined a Mediterranean diet, which is kind of vague. It's like, well, it's what people eat in the Mediterranean. Well, you can find someone in the Mediterranean that doesn't eat healthy and someone that does. So they tried to distill the Mediterranean diet down to its essence by studying like what are the healthy elements of it by using very carefully done diet controlled studies. And then they added the DASH diet as well, which is a blood pressure lowering diet. And they came up with the MIND diet. And the MIND diet emphasizes 10 healthy food groups. And this is on the next slide as well. But chicken, fish, leafy green vegetables, other vegetables, berries, nuts, olive oil, wine, beans, and whole grains. So those are the 10 things you should be doing. They also recommend avoiding foods like cheese, butter, margarine, pastries, sugary foods, red meat, and fried food. All the foods we want to eat this month, right? For Christmas or Hanukkah or whatever else. So again, more evidence for just specifically the MIND diet. So they did a survey of 923 people in the US. They followed for 4.5 years. They looked at people who adhered to the MIND diet, and people who are more likely to adhere to the MIND diet were less likely to develop Alzheimer's. And this is a book. Martha Claire Morris did pass away from cancer a couple of years ago, I believe cancer. But she left a legacy at Rush University, and a lot of people are continuing to study this. And her daughter, I think it's her daughter, Laura, provided some recipes. This is a fantastic book. And I think I donated a copy to the hub. If it's not there yet, I will bring one over. So anyway, just a fantastic diet. It's really science driven, and it's also fun to eat. And it tells you a lot about what you can eat instead of don'ts. It's not the 10 commandments. It's what you should be doing, which is fun. I mean, there are some don'ts, but there's some do's. One of the things I really like to emphasize with diets too, unlike medications where you can either take it or not, diets are something we all have to do. We all have to eat. So when you make a change to switch from red meat to fish, I like to talk about that with my patients as being an interception for a touchdown. So not only are you not eating the red meat, you're also eating the fish. And so it could be that you're taking away points from the other team and you're giving points to yourself for health. I think sometimes that's why it's hard to study these things because you can't really study them in isolation. Unless you're eating a lot of food, usually when you make a food choice, you're disavowing another food choice, right? If you're eating a leafy green vegetable, you're not eating something else. So it is hard to study these things. And one of the things that I'm really having a dilemma with my E4 carriers is are high carb diets bad for them, or are high fat diets good for them? Because the data that I'm working from, I can't tell because I'm comparing data from both diets. But it may not matter, if you make these changes and you're feeling better. And we just know from common sense and from heart studies and from other things that this kind of diet has just been shown to be healthy, over and over from lots of different studies. But yeah, I like to talk about the interception for a touchdown or interception for a goal or whatever sport they're into. So that is something I emphasize. These are just a couple little nuggets of studies. So this is a very small study. I should update this, but blueberry juice improved memory in an open label study, another Rush study. So this comes up a lot. When we say that seafood is healthy, do we mean fish or do we mean fish and shrimp and lobster and crab? And we all know that when you eat lobster, you're also eating butter, because obviously. Well, it turns out when all seafood is studied, it turns out that seafood does seem to be healthy for you, even when you study shrimp or crab. So, and I'm wondering if we're seeing the interception for a touchdown effect here. Because if you're eating, even if you're dipping that lobster in butter, which is probably not healthy for you, like a couple of bites of lobster with butter is so rich and filling, you're not eating the steak, you're not eating the red meat potentially. So it could be still that it's healthier. And it's also expensive. So you just literally can't eat that much lobster. I can't. So bottom line, seafood is healthy for you. But some people, when they study seafood, they just focus on fish. Other people combine them all together, and it's a little bit murky and troubling to study. When you just give people fish oil supplements, it's not as strong of a signal than eating the seafood. Mixed nuts, there's a lot of studies about that. And then there's some studies for curry that does seem to help nerve cells in the lab. So stay tuned for those kind of studies. So these are individual foods that might help, that kind of supplement, what you're eating for the mind. More examples of individual foods. So leafy greens. So these are those Rush people again. people who ate at least 9 servings of leafy greens score better on cognitive tests. And what they mean by leafy greens: spinach, lettuce salad, kale, collards, and greens. And then foods high in flavonols include beans, apples, blueberries, olive oil, tea, and tomato sauce. So we talked earlier at the beginning of this about, salad. I think, salad, if you're just eating like iceberg lettuce and ranch dressing or whatever, that's probably not a true leafy green. But if you really get the spinach in there, I mean, a spinach salad is a objective leafy green that would get you one of your points on here. I apologize for kind of a lot of text on this table, but I just really love this table. It came from that review paper that I mentioned. And so hopefully y'all will get these, or these slides can be sent out. Or if you want the paper, the reference is at the bottom. This compares the Mediterranean diet, which is again kind of vague, right? It's like saying the Japanese diet or whatever. But as best we can distill the Mediterranean diet down to a list, this is what the Mediterranean diet is. The DASH diet and then the MIND diet kind of side by side. They're very similar, but they're not quite the same. But if you have a patient that's really motivated, like my mom, she will not give up her salt shaker. I cannot wrench it from her hands to save my life. She loves her salt. She's not going to do it. She's just not going to do it. But she will supplement her diet with fruits and nuts and stuff like that. So if I'm going to do anything for my mom, it's going to be Mediterranean diet. And I have her permission to talk about her, by the way. So hopefully that's not a HIPAA violation. Whereas like for me, I don't care about salt, but I really like dairy. So I might be more likely to follow a DASH diet. So, really, this I think might be helpful to pull out when you're like, what's my patient more willing to follow? Or if they really have hypertension, the DASH diet's more important. So I just really like this one because you can kind of tailor it to what your patient eats. Or, if they can't eat fish or seafood, then you can just ignore the two ends, like stuff like that. You'll notice these are all very, Mediterranean is very Eurocentric. There are other continents on this earth, like many more. There's Africa, there's Asia. These are woefully understudied, and thankfully they are starting to be studied and published in even European journals, and journals in written in English, so we can read them. This is a nice study I found about Japanese diets. They found 3 patterns identified from cohort studies identified with less cognitive decline. And this came up actually at a poster I just saw at CTAD in Korea. Eating a diverse diet. And the way they did this was, if you were a picky eater, it was bad for your brain. And I just thought about myself as a kid, and I kind of was a picky eater. Oh no. But if you like eating a variety of foods, so diverse diet, high adherence to pattern 1, which is high intake of beans, soybeans, vegetables, seaweed, milk, dairy, and low level of rice, which is kind of interesting, right? So low level of rice was actually good. And then the pattern 2 that was healthy in the Japanese study was fish, vegetables, mushrooms, seaweed, pickles, soybeans, and green tea. So I went back and read the 2 cohort studies. One included shellfish as fish and one did not. So that's why I said earlier, it's complicated. Is shellfish fish or not? Yeah. Sometimes. There are, of course, many, many other diets. This talk could be an all-day seminar. I don't know how many of you have heard of someone going on keto or intermittent fasting, or late breakfast, they're not eating breakfast or any of that kind of stuff. This is such a fascinating topic, and maybe my next R01 will be about something like this. My former mentor, Dr. Kraft, is studying this quite heavily. This is some data from her lab. The idea is when your brain stops producing or stops being able to utilize glucose like it does in diabetes or in Alzheimer's, it can use ketones instead. So why not just give your brain ketones by either following a ketogenic diet or by giving someone a ketogenic supplement? And there's some promising data to suggest that this works. These were some studies of, she did a pilot study of a modified ketone diet. So it was just barely ketogenic, about 10% carbs, 60 to 65% fat, 30% protein in 20 adults with cognitive impairment. And they got better, their CSF got a little better, their perfusion got better, and their ketone body uptake went up. So now bigger studies are ongoing to see if that's okay. The ketone diet is not for everyone though. It's quite a bit of fat, pretty low carbs. It can lead to micronutrient deficiency if you're not careful. And it's contraindicated in liver and kidney disease. And it can be difficult to follow long-term. So if someone really is serious about wanting to go on a keto diet for like prevention or wanting to do this to like slow their MCI, my advice is to send them to a dietitian just to follow along, because I think it's difficult to follow this, and they can follow some of their labs and make sure they're doing it safely. Same with intermittent fasting. You know, if they're young and healthy or whatever, but I mean, if they're older, you know, I don't know. It makes me a little worried about an older person who might not be drinking anything. You know, they're already prone to dehydration and prone to issues where they're just going to go intermittently fast. So there is some promising evidence that this might work, and it's being actively studied, but the long-term success in our patients who could have all kinds of diseases, be on all kinds of medications, I think the long-term success is unknown. But I would say that fasting has been independently discovered by like every religion as being something that helps us, you know, center and find our soul and all of that. So I think there's something to it. I love this topic. I can't wait to hear more and be a part of this science. And you can incorporate it into religious practice too, which is great. All right, of course, everyone wants me, when I give nutrition talks at community, they want me to talk about alcohol. The very short story is alcohol in moderation during midlife, which we define. Oh no, I gave a different definition than the Lancet. I'm inconsistent. 40 to 65 can lower the risk of heart disease and stroke. For older adults without dementia, though, we recommend limiting to 1 drink a day, and some are actually advocating none for neurodegenerative disease. For persons with dementia, just minimize because it can increase confusion and falls. That's kind of my party line, is if you have dementia, less is more. It does not prevent dementia once you have dementia. This is some little nuggets of wisdom from that Global Council on Brain Health PDF that I talked about before. Again, if you go and find it, I guess it's Global Council on Brain Health on Nutrition from 2017. These are things I've kind of already talked to you about that are really truisms that keep coming up. But diet impacts brain health. What is good for the heart is good for the brain. The typical contemporary Western diet is not good for the brain. They recommend the Mediterranean diet, the DASH diet, the MIND diet, which you've seen already, the Nordic diet, which is pretty similar to all the other diets. A lot of seafood. No single food acts as a silver bullet. You can kind of read these. These are basically the same kind of things I've been talking about. Excessive alcohol and salt can contribute to bad stuff. And you can give this handout to your patients. You know, they can just kind of look through this and go, oh yeah, okay. So I alluded to this earlier, but for patients that I see in this clinic that I'm sitting in, for people that come to me for dementia prevention or that have early stages, I think preventing further decline is an important goal. So I circle their hypertension, like with a big red marker, and I'm like, go talk to your primary. And I tell their primary, and I give them recommendations on medications. And, you know, I give them recommendations on diet and all the other things they could be doing. And exercise. I mean, this talk, I didn't talk about exercise. Exercise is very important. Pick a diet you can live with. You know, like I said, my mom's just not going to give up salt. This is what it is. Nutrition consult, if available in your area, and they can help people make those choices. I think nutrition consults are really underutilized. Even my, pharmacists can probably help with some of this, but nutrition consults within your institution or even outside the institution, can they find a dietitian that can sit with them a couple of times and go through what are the things that are the most harmful? What can lead them to an interception for those touchdowns, like giving up some soda, replacing their soda with water, replacing their red meat with fish, that kind of thing. For middle stages now, for middle stage dementias, I really talk about appetite, swallowing, and hydration. That's where I really focus a lot of my review of systems. Are they getting enough protein? Are they getting enough calories? So their leg strength is up there. Are they falling? Now I'm more kind of a geriatrician. For late stages, I think I already told you my trademark diet. Let grandma have the ice cream. This is not the time to roll out the mind keto diet. Like, seriously, you're not going to cure their dementias. So those are my slides. I hope that that was helpful and that I left some time for questions. And we can chat. Yeah. Anyway, that's what I put together for you all.
Oh, Angela, thank you so much for putting that together and your time and expertise. I will also let our community know that you have the most viewed article on our Memory and Brain website, which is the diet for the aging brain. So we'll send you that link too. But as long as you've got a couple of minutes to stick around, we definitely have time for questions. So comments, questions from our community for Dr. Hansen?
Somebody asked in the chat if they can get the slides. I'm happy to share my slides. So I sent them to Allison. I don't know if there's a way to mass send them out or.
Yeah, so we always post the slides on our website. Great. And we also, in the invitation to our next session, it will be included. What we will include is the link to this session's resources.
Great.
And I think I put the right Global Council for Brain Health thing in the chat also, but we'll send that out as well.
Oh, and that might even be the updated one. So I'll have to look through that. That's fantastic. Thank you.
Sure.
And I'll just go ahead, since I have everybody, I already sent out the survey to everybody. So I'll just use that email list again and paste in the slides. I'll send it out right now.
I'm just thinking of other, getting back to what the title was top, practical things. I tell my patients things that I personally, when I go to the store, really load up on nuts and fruits, like, really just try to avoid having junk food in your house. Like Costco, take the stuff out, put the just make concerted effort to put things in your home that are healthy for you when you're snacking. So nuts and fruits to snack on, I think, is a big thing that I've done in my own life that was an easy change. Drinking more water, getting rid of soda. I think those are personal things. I think there are, one thing I'm kind of interested in is sort of, I talked about community and communal solutions, and I'm just as guilty of this as anyone else. I have some Ghirardelli chocolates for my staff, but when someday we have communal feeding again, like donuts probably need to go away and we should be bringing in more wholesome, food that we cook for each other. That kind of thing. Like what else can we be doing as communities, like individual choices, community choices? Taxing soda was probably a thing that helps. I know it's Big Brother and all that, but it literally probably saves lives. So it is what it is, because the human brain wants sugar. So. When looking at the alcohol question, alcohol being protective in moderate amounts, I've had people asking this as well. What do you think about the impact of alcohol itself being possible confounding factors, with alcohol being linked with social engagement or other personality traits or activities? From Lynn, yeah, thank you. I think it's so tricky. I mean, it's a good question. I don't know. Maybe I'll ask the group if anyone else has a good approach. I mean, one of the things we do screen for, we do a audit. We do an audit screen in our clinic. So to identify problematic drinking. And if it's not quote unquote problematic drinking, I don't necessarily do, like, they have 1 or 2 glasses of wine at dinner and I let it go. But I think we probably underdiagnose problematic drinking, and but in terms of it's problematic because you probably drink too much wine because it's too much for you because of it, the health problems with it. But I don't know if other people have thoughts or suggestions about that.
I'm not sure if it's a suggestion or a different question, but I see Jeff Kaplan has his hand up.
Hi, Angela. I guess my question would be processed foods versus unprocessed foods and ultra processed foods. What's the evidence with that? Michael Pollan tends to talk quite a bit about real foods and avoiding the ultra processed foods. Could you comment on that?
So I don't know. I have to be clear. I don't actually know what a processed food versus an ultra processed food is. Do you want to define that? I don't actually
I'm
know.
not a nutritionist. I'm a primary care doc, but the processed foods includes dairy is processed. Ultra processed are in boxes with a large list of ingredients. And so I think the current things I'm reading are saying for most Americans, about 60% of their calories are ultra processed. So it's stuff that's gone through more than one stage and additive to further refine it. And so a lot of my counseling, although I can't honestly claim that I'm very effective because my big people stay big and and those with good habits continue to have good habits. But it's sort of a theme I pushed on. It's just that people are overwhelmed to go into a grocery store and they refuse to stay on the boundary of it where the either real foods are or just processed foods. But I'm not sure a coherent definition.
Yeah, that's a good question. I mean, I don't. So the people that study these, like mind diet kind of things, when they talk about vegetables and fruits and things like that, like canned fruits and vegetables still count as fruits and vegetables. So they don't necessarily get into that level of granularity from that, like canned spinach, and you could go, oh my God, you could do like a rabbit hole deep dive into that. And like what I've come to decide is that a vegetable is a vegetable, so if it's canned or processed or whatever. So I think that it really still comes down to what the food is. So are they eating a lot of simple sugars? Are they eating a lot of whole grains? So okay, so USDA says anything that you're doing to the food, heating, freezing, dicing, juicing is a processed food. So to me, processed ultra, it sounds like I'm going to take a step back a little bit, and I'm going to take on 2 personalities. One is, it sounds a little bit like inflammation, like processed food, and I'm going to sell you this whole food. I don't mean Whole Food like the company Whole Foods, which by the way is bought by Amazon, so whatever. It's not Whole Foods. I don't think that packaging food to make it last longer in our fridge makes it unhealthy. I just don't believe that's the case. I do think that we do eat a lot, like too much, like simple sugars, and it's easier to eat simple sugars now because they're put in a package, if that makes sense. Like you couldn't eat simple sugars 10,000 years ago. Like there weren't any such thing as Smarties or Kraft macaroni, right? There was only berries and red meat, that and fish. So I think, you know, packaging and processing foods has led to like an enormous amount of reduction of poverty worldwide. But it's also led to the ability to just store an enormous amount of food and have a lot of food around. So I think we just have to be careful, like, oh, processed food, you know, if you eat a huge giant spinach salad and you eat 7 servings, you're still eating too much. So I don't know, I'm probably going around in circles. I think that what we know from the science is the types of foods still ultimately matter. Come on in. Is my patient here?
Yeah.
Okay, sorry, I'm still giving my talk, so I will be right out. I see that they've scheduled. Yeah. My patient's here, but they're not scheduled till 1. Yeah, I don't know if other people have thoughts on this. I mean, I guess I'm a little skeptic about the whole, like, you need to eat a whole grain, GMO free, modified, you know, all of that kind of stuff. I think food is so I'm just going to put my label on my sleeve about that. And I also think that kind of mentality sort of like makes it hard for people to afford food sometimes. Like there's a lot of people that can't afford to shop at Whole Foods, and that doesn't mean they can't eat healthy. So you know, I think if you know, if you're feeding 3 kids and you have to buy food that's quote unquote processed because you can't buy fresh food every day at 9 a.m. at the store, like obviously you're going to buy. So I don't know if that's what you're asking, but I'm probably going on around circles. But feel free to jump in and tell me if I'm on that kind of track, or if you're asking something completely different. I think it really comes back to what is the food that you're eating. If you're eating a processed spinach, it's fine. Process it and eat it. It tastes great.
I'm curious if Dr. Gaster has similar thoughts or is going to go somewhere else with this.
Yeah, I was just going to comment on Lynn's question about alcohol. So not processed, not processed foods.
You sure? How about Franja?
I would like to acknowledge that I really appreciate that you're meeting people where they are and that you're making it approachable and trying to keep it simple, because not only for socioeconomic reasons, I think that when I talk to like children whose parents may have cognitive impairment or dementia, there's so much anxiety, stress, and they want to do a good job. And so empowering them to kind of keep it simple and not lose themselves in the anxiety and the stress. And also, you know, if you have a new diagnosis and then you want to do everything the very best. So, I appreciate what you're saying is the take home message and the idea of trying to kind of keep it simple, and that if you're going to do something more complex, do it with an expert who can help guide you. So thank you.
Thanks for that.
Other questions? If not, Angela, we are happy to release you to get ready for your next visit. Or going once, going twice. All right. Well, thank you, Dr. Hansen, and we will be sure to send out the slides, and we'll also direct folks to some of your other pieces on our Memory and Brain website. There's some great information there as well. And if you want to hang around while Dr. Gaster shares his perspective on alcohol, you're more than welcome, but you're also welcome to drop off anytime you need to.
All right, I think I'm going to go see my first new patient of the day. See if they have diet questions. Well, thank you so much, everyone. I really appreciate you being here. And I always learn a lot from also your questions. And so now I'll know to look up processed food and update slides. And this is just an exciting, fun, big topic to learn about. And we all eat, so it's great. Thank you so much.
All right, thank you. All right, Barack, what were you gonna share about alcohol?
Yeah, I mean, I was just gonna say, I mean, this is like definitely one of the questions that comes up the most about alcohol, and the way that I frame alcohol in cognitive impairment is to really make a really big distinction between what we usually think of as alcohol use disorder in somebody who doesn't have cognitive impairment, in which we're really focused so much on, you know, how much does being drunk functionally affect your life. And that's, you know, like rather than sort of like it's this many drinks is what sort of crosses the line. It's really this functional definition. But that when somebody has cognitive impairment, it's really a completely different ball game, because you're dealing with a completely different brain. You're dealing with a vulnerable brain that is at risk of what I almost think of as like a alcohol-induced delirium that can be caused by 2 drinks. You know, so, you know, and it's not the sort of just the few hours after having those 2 drinks, but it really can be like a persistent problem that can last for a day or more. That when I talk to primary care providers and families and patients, it's really in the same thinking of ways that, you know, somebody who is 50 and gets a UTI, it's not going to affect their brain. They're not going to get delirium from that. But somebody who is 75 and has cognitive impairment, that UTI can like really throw them for a loop, and it can persist for like days even after the UTI has been treated. And I think of alcohol having that same effect on the vulnerable brain, such that like somebody who has been drinking 3 drinks a day for their whole life and it's never been functionally a problem, and you would never think of them as having alcohol use disorder, who now has mild cognitive impairment, really saying, you know, if we want to maintain your brain health and keep your thinking as clear as it can be, then those 3 drinks are not okay anymore. And, you know, whether 1 drink is okay is you know, you can only know by sort of trying. But I would say, you know, I think it was on one of the slides that really probably like the best party line answer is, you know, no alcohol for somebody who has mild cognitive impairment is probably the best. And, you know, but Lynn, your what was in your question about what about the socialization of alcohol, you know, so important to acknowledge that, but really telling somebody that their socialization is actually going to be impaired by that alcohol, and that finding a different beverage to have as part of your socialization is going to be much healthier for your brain than the alcohol.
That is such an interesting topic, and you know, we hear this a lot with our older adults who live in senior living, including assisted living, that, you know, the happy hour, the wine hour is such a key event, and, you know, oh, can I not go now? Or, you know, it really brings up so much. Karen.
There we go. Hi, everybody. It's Karen, the caregiver perspective person on this Echo Dementia. And just a couple things I'll say. Alcohol, agree with what Dr. Barack just said. And also to add that alcohol really can interfere with sleep patterns. And since quality sleep is one of the main modifiable risk and progression factors in dementia, that's just also something else to think about. And I was recently on a neuro nutrition webinar, and they were saying, if you are going to drink that 1 glass of wine, do it at lunch, not at dinner. And that changes socialization too. Like now everybody's having a wine lunch instead of wine at dinner. But at any rate, my husband and I were teetotalers for decades before he developed dementia. So there wasn't an alcohol component to our change in nutrition. But I'll just say from personal experience, he was first diagnosed in 2015 with MCI when he was, I guess not asked, but told that he had to quit practicing as a physician. So for how many years before that the MCI had been going on? I'm sure it was several. But then in 2018, well, and initially he said, I don't want anybody to know, I don't want to do anything different. Okay, fine. Then of course the dementia was progressing and he was starting to have a lot of vacant looks, not getting sense of humor anymore, where his whole life was about humor and jokes and fun and everything. And so he was becoming quite zombie-like. And then in 2018, a friend of mine turned me on to the book by Dr. Dale Bredesen, who's the neuro researcher out of UCLA. And he had diet suggestions in his book. And I just said, okay, let's just try this. We don't need doctors for this. Let's just do it. And so I told him, I said, I'm going to do the diet with you. So that's in listening to what was just presented and so forth. It's partly what you eat, but how you get there, like that change process. And getting the family on board, getting the primary care partner on board with it. So I said, I'm going to eat exactly like you. And his birthday is December 24th. So I said, okay, December 23rd is your sister's birthday. And then the 24th is yours. 25th, we'll do Christmas. And 26th, we're going to go cold turkey. So we just went cold turkey, a bunch of food in our house, went to the, I felt kind of bad, but went to the food bank. Let's give all our sugar and simple carbs to the food bank. And we just started the Bredesen diet. And by Valentine's Day, his sense of humor had come back. He was tracking TV shows again and so forth. So the Bredesen diet is pretty strict. They say most people can't handle it. We've been on it. This is for 4 years now, this month. And of course, his dementia is progressing. I didn't expect any miracle cures or anything, but I think the anti-inflammatory piece of it, getting off the simple carbs and the sugar, was immensely important. And I've heard alcohol described as liquid sugar because it also is processed by your body in a highly caloric way and turns into carbs and so forth. So at any rate, that's just our personal experience. We're still doing the Bredesen diet. I recently had a diagnosis where now I have to introduce dairy back into my diet, which I'm doing, which I'm glad of because I've really missed it. But part of his success in keeping to this diet, which he likes, I've also heard that taste buds like change in your mouth every 2 weeks. So what we eat is kind of a lot of habit, not necessarily preference. And so he loves mushrooms now, which is great because that's super great brain food. But anyway, it was just that whole process and then his sister started going on the Bredesen diet so that she would understand what it was, so that she could also serve meals, and all of our friends. So that socialization. I remember an early dinner where we were declining pie and ice cream, and a friend was like, but you have to live, you have to have fun. I said, well, our definition of living isn't pie and ice cream anymore. It's something else. So sort of learning some of those ways to manage social situations. And now all of our friends who invite us for dinner and so forth, like, what can you eat? What can I make? I said, we can just eat around the table, but they really want, it's something they can do. Like, oh, what can Scott eat? What do you guys eat? What can I serve that will work for you? And it's something, our friends feel pretty impotent about what they can do to help. But that's one thing. So it's just kind of engaging our social scene and our family scene in presenting foods on the table that we can partake of as we're being socially engaged with them. So those are just a few thoughts that were running through my head, and I'll mute myself now.
Excellent.
That's probably
No, thank you for that. Appreciate that. And Nancy, I saw your hand up too there for a minute.
Yeah. Thanks, Chris. So I really appreciate the discussion and the presentation, and I think that one of the things that is sort of an umbrella here is the normalization of so many habits that may not be promoting health. And how do we, and also the policies around food. So when Jeff asked his question, I think we were getting a little mired in processed, but certainly ultra processed food, where you have high fructose corn syrup and loads of salt, like fast food. We know that is contributing to obesity. We know that is which is an epidemic, and which also is a risk for Alzheimer's disease and other dementias. We know that most dementias are mixed, not simply Alzheimer's. And so I feel like, for our colleagues here today in this community to kind of broaden the discussion and say, gosh, alcohol is normalized, donuts are normalized, and then meeting people where they are. And furthermore, you know, our recommendations around nutrition in the States don't even talk about food. I mean, they won't even like meat is not mentioned. And then we have the subsidies around food. So we don't have the biodiversity of food, which would improve our, you know, microbiome and the brain. And so these studies are really hard because they're all correlational studies, right? It's food studies. We're not going to be able to do a double-blind, randomized, prospective, gold standard of a study. And yet, I would say that we now currently are in a place where we can say, as Angela said, as Dr. Hansen said, you know, that fruits, veg, beans, greens, nuts, seeds, and meeting folks where they are. And, you know, in prevention, and then there's kind of emerging data around fasting and ketogenic diet. And then, of course, liberalizing and like with enjoy your ice cream, but that so many things are normalized within our society, and that these policies have not really made the healthy easy, because there's so much, unfortunately, you know, so much political bad will. I mean, I don't want to get, but you know, we're not creating policies that promote health. So that's maybe a bit further afield, but we really have not in America made policies, and the soda tax barely has passed, but we're not, I mean, the cost of meat is totally subsidized. So I will stop there, but I just think to kind of talk about the normalization of unhealthy food and how that is contributing to this public health crisis.
I guess, Nancy, what we face, at least here in Yakima, almost every restaurant's a fast food restaurant. I think there's two places that aren't, and our own organization for trying to acknowledge how bad things have been here sends around a donut truck. The messaging and in schools, my wife was a recently retired school nurse, and rewards are the wrong rewards, and yet we go around and around on this without change. I suppose what's most frustrating for me as a primary care doc is it's really hard to help people through these changes, and nobody has the time. There aren't the resources, and what's easy and cheap, as you're suggesting, are the things we least want people to take. I mean, water is more, if people who choose to buy bottled water, and in parts of our community, their wells are bad, bottled water is more expensive than soda. And I'm not advocating for bottled water, but it's sort of an irony. And nobody I've ever spoken to has had a really, unless you're going to incarcerate somebody and give them good food, which they don't get when they're incarcerated, we all feel sort of stuck because public policy is aligned with the wrong habits instead of the right habits.
Yeah,
Jeff,
I mean, I think there are beacons. I'll just add, I mean, I think I take your point, and that's unfortunately the majority. And then there are these sort of beacons of light around medical food efforts and around food systems, centering of culinary medicine, food pantries, gardens, teaching kitchens that are happening in various areas. And Michelle McMacken and Eric Adams are doing amazing work in New York. So I do think that there are some, I think it's a movement, and I think that I'm cautiously optimistic that there are shifts happening, maybe in part because of COVID pandemic, but I'm cautiously optimistic, acknowledging, as you say, Jeff, that like fast food is everywhere and we don't have time. It's hard to have those discussions in the office. And there aren't culinary, teaching kitchens in every hospital. But there are programs for diabetes now that are paid for with nutrition and with teaching kitchens, for example. So we just need to continue to leverage those in creative ways as well, and shared medical appointments where people can support one another. So I'm really hopeful, understanding it's hard and behavior change is incredibly hard and happens more within a community rather than at the level of the individual, certainly.
Yeah, it would still be nice if bottled water wasn't twice as expensive as Coke here at Harborview in your vending machines. So yeah, Barack, what else would you like to add? You're still muted.
Thank you. Just want to give like the perspective of sort of like, you know, kind of addressing primary care and addressing public health departments about how we just like made tremendous sort of progress in the last 20 years talking about heart health. Like people understand like what heart health means when you talk about diet. I mean, all you need to say is heart health, and people like, you know, that has just been branded and messaged so successfully. And that it just to keep it really, really simple, I think, you know, our science is at a point where it's really like every time you say heart health, you can just sort of like, you know, copy and replaced with heart and brain health, you know, and that can just be so just like simple and direct, and people like the public understands that. Public health departments, you know, can make that change. Primary care can make that change. And it doesn't have to be like super complicated, you know, well, what is the MIND diet and how is that different? And I mean, there's going to be some people who want to get into the weeds of that, but I will also just say that, you know, it's just so tremendously difficult to do good research in diet science to really kind of like differentiate sort of one thing from another. But I think I think heart and brain health is the mantra that I think could have some wheels to it.
Absolutely. And in that vein, I will also share with you, kind of a continued conversation, perhaps, our next session for Echo in the new year will be Friday, January 13th with Beth Frades, Dr. Beth Frades, doing a didactic on lifestyle medicine for prevention and management of dementia. So I'm sure we will hear more about heart health and diet and exercise and all the non-pharmacological things we can do. So stay tuned. We'll kind of maybe pick this up in the new year. We've got a couple more minutes. Any other kind of last minute questions, comments, items of business? Pressing clinical items that we can address in 4 minutes? Maybe not that. Going once. Going twice. All right, we'll give you the gift of a few minutes back in your afternoon, and gratitude for participating in this wonderful community, and really just appreciate all the enthusiasm and engagement. So we'll see you next year.